So now from the diagnosis, let's move on to the fluid management, which is very tricky in this patient. This is what we look into, because if it's a sepsis, then we all know we have to give quite a good amount of fluid. But here, the situation may worsen the shock, and we have to reach a balance to achieve a success story. So once you suspect a septic cardiomyopathy, our fluid strategy changes. So how do you balance fluid resuscitation with the risk of under resuscitation as well?
Right. So we know that fluids should only be given.
With under resuscitation.
Yeah, this is a really great question, and this is a dilemma that we face every single day. We know that too little fluids can be deleterious, and we know that too much can be bad as well. We know that the Surviving Sepsis Campaign guidelines tell us to give 30 mils per kilo, right? We are shifting not away from 30 mils per kilo, but we're shifting a little bit away from giving 30 mils per kilo all at once. We're saying give 10 mils per kilo, reevaluate, 10 mils per kilo, reevaluate. But it requires that we're vigilant. It requires that we're there with our echo and our functional hemodynamic test or fluid responsiveness test. So fluids should only be given if you think the fluids are going to improve cardiac output, right? So you would need to do your fluid responsiveness test. So we know that you could do it with your, passive leg raising. If you're not, if the patient is a little bit short of breath and you're not sure whether or not the patient is going into pulmonary edema, or whether the patient can tolerate fluids, if you're worried about the right ventricle dilating, you could do a passive leg raising test. If the patient is fully mechanically ventilated, and most of these patients are in early phases of sepsis with ARDS, you could do a tidal volume challenge, as Sheila Professor Miatra's tidal volume challenge, excellent test. You can also do a PEEP test. You can do an N-expiratory occlusion test. So all of those tests you can use. There's a huge range of tests that we can use, and not all of them require a cardiac output monitor. So that's how I would approach fluid responsiveness, fluid management in this patient.
It's very important to look into the non-responders and to avoid that determining effect of the volume overload. So what are and you spoke about all those dynamic indices. So are there any critical limitation of those indices you want to speak on?
Yes. So PPV is excellent, because everybody has an arterial line, at least if they're as sick as this group of patients are. So the pulse pressure variation is a very good indicator of fluid responsiveness if the patient is being ventilated with more than 8 mils per kilo. You can't really use it in spontaneously breathing patients because, it will vary widely. So you can use the PPV if your tidal volume is more than 8 and there's no spontaneous breaths. If the tidal volume is less than 8, then you need to use tidal volume challenge. You can't use PPV if the heart rate is very high or very low, or if the patient is very tachypneic, for example. You can also not use it in arrhythmias or in patients with intra-abdominal hypotension. So there are very certain limits to it. Things like the N-expiratory occlusion test, well, you need to stop expiration for 15 seconds. That's quite a long time. So maybe, in patients with severe... Yeah, it's difficult to do as well in some patient populations. Passive leg raising, also an excellent test, but it's passive. You have to do it with the beds, and you cannot touch the patient. So there are all these limitations to some of the tests, but usually it's possible to find one test.
So majorly you said PPV we can't be using if the tidal volume is less than 8. If patient is spontaneously breathing, heart rate is too fast, or maybe there's an arrhythmia. That time we can go with the low tidal volume challenge test, which is a better one. And of course PPV needs lots of understanding. We don't have to touch the patient has to move. So whatever we use, we need to understand the limitation, and then accordingly we pick up one test and use accordingly. This is what the message.
Indeed.